Yep, that's us live on Facebook now as well, so all ready to go. And we're recording on here too. So thanks everyone for joining us for our Q&A session today. I've got Professor James Neuberger with us today. Hi James, how are you?
Hi, afternoon. Lovely day today, isn't it?
Oh, it has. It's been gorgeous up here as well, actually. It's been really nice. Still a wee bit chilly, but very lovely. So just to remind everyone before we start that these Q&As don't take the place of a consultation with your own clinician, and we aim not to provide medical advice, but to provide general medical information. Also, please remember as well, if you're watching on Facebook, that that's a public forum, so just be aware of what you're typing in the chat box there as well. And remember that for a bit more privacy, you can join us in the Click meeting room here with James and I. So we'll get started on the questions that we have in the that have come in this week, and I'll also keep an eye on Facebook and in Click meeting here to see if there's any questions coming in as well. So we'll just get started on that. So the first question I've got today, James, is we've got a 76-year-old female diagnosed around 5 years ago, but clearly had PBC for many years prior to that. Suffered from food intolerance for many years, but in recent months it's got much worse. Also intolerance to medication that they've been taking for years uneventfully. They're asking if we think there's a link between PBC and food tolerance. Could PBC be to blame, and any remedy for that?
Right. A number of issues, really. I think the first is what people mean by intolerance. And like many phrases that people use in normal speech, it covers a multitude of possible issues. So sometimes there's a true allergy. And examples of that are obviously celiac disease, where there's an immune response to gluten in wheat, and that's an allergic thing, and people get untreated, unrecognized. Certainly it can cause major problems, and certainly in the old days, before people were aware of gluten-sensitive enteropathy or celiac disease, children failed to thrive. They were small, they had rickets, they had all sorts of other problems. Now we're better. And so that's a true allergy. Another form of allergy is something that, for example, food allergy, when people say are allergic to strawberries, they have strawberries and they come out in a rash. So those are true allergies in the medical sense. There is an immune-mediated response, and treatment usually are very simple. It's just avoidance of whatever precipitates the allergy. Then there's a sort of broader food intolerance that some people find some foods upsetting. So a number of people find gluten difficult to take. They feel uncomfortable. They may get bloated. They may get diarrhea. They're not truly allergic to it, but they do, if you like, react to it badly. And and again, the secret then is just to avoid gluten. If you are intolerant, say, of gluten, and you have it, then you may get the symptoms of bloating or whatever the symptoms it causes you, but there are no long-term effects. If you're allergic to gluten, as true celiacs are, then you do get associated problems which can be severe in some cases. So intolerant, again, can be transient. So after, for example, gastroenteritis or other bowel infections, your bowel can become intolerant, say, of lactose, and transient lactose intolerance after an illness is not that uncommon. And again, you find those foods that precipitate your symptoms and just avoid them. It's no big deal in theory, but obviously if you like cream cakes and you're intolerant of lactose, then it is a problem. And you have that difficult choice of, do I have a cream cake and diarrhea, or do I have no cream cake and my bowels are okay. And that's a decision for the individual. And then there's a sort of more generic intolerance that people say when they're feeling unwell. They just don't like any food or some foods or certain foods. It can be transient. And of course, being intolerant of medication can be a real problem because you've got to weigh up the benefits of the medication against the risks. So there's several things when I read that letter first that came to mind. The first is, what does that person mean by intolerance? And the second thing is, I would always advise caution about symptoms that are new. She's had PBC for 5 years, and this is a new symptom. There are many potential factors that might have precipitated this, but I would always advise that any new symptoms to go and discuss with her GP in the first case, or the nurse, what does she mean by intolerance? And what has changed to cause it? It may be something of nothing. It may be that the medication or the food or whatever is causing just a bit of upset, if you will. But I wouldn't ignore it. I wouldn't blame it on the PBC. Certainly when people have marked cholestasis, when they're jaundiced, certain foods can make them feel unwell. So for example, if you are jaundiced, then you may be more intolerant of fat because you don't get enough bile in the bowel to help absorb the fat. So you get bloating and discomfort. So it may be part of the PBC, but again, new symptoms that cannot be readily and simply explained need to be investigated further. And I think it's probably nothing serious. It's probably nothing to worry about, but you want to know for sure. So go to your GP. Whilst you're waiting for the GP or the nurse, it's worth thinking, are there certain foods that precipitate the symptoms? And in extreme cases, you can go on an exclusion diet, but again, talk to your GP first. But if it does come and go during the day or during the night, try and see if you can relate it to certain foods. And then if you cut out those foods, does intolerance go away? Or equally, if you take them in larger amounts, does it come back? So if you can relate it to anything you're eating, that's obviously very helpful. But I think the two messages I have is, don't just blame it on the PBC and take it seriously. Go discuss it with your GP and see if there's anything underlying it. And again, if there's anything you can do to mitigate it. And in the meanwhile, look at what you eat and see, not just is it sort of bread, butter, but is it fat? Is it protein? Is it wheat? Or whatever that's causing it. So sorry, it's a long-winded answer, but I hope that explains the background. But do take it seriously. Do go and talk to your GP or nurse and try and work out, exactly what you mean by intolerance. Is it associated with diarrhea, nausea, vomiting, bloating, gurgling of your tummy? Is it related to certain foods or to meal times? So the more information you can give your GP, the easier it will be to nail down what the cause is. And once you have the cause, then you can discuss treatment if it's needed.
No, that's great, thank you. The next question mentions an intolerance to urso. So we have a patient who has PBC, but not on urso due to intolerance. They've been advised to have an infusion for their osteoporosis, but has been warned of side effects and potentially needing steroid treatment. It doesn't mention what type of infusion, it just notes infusion. They've had an eyelid cancer operation and some reconstruction, so trying to be aware of this, what this treatment may incur, and if we were able to offer any advice on that.
Right. So osteoporosis means that the bones are thinner. Now, as you get older, as I get older, as anyone gets older, your bones tend to get thinner. And as they get thinner, they are more likely to fracture. And that applies to all the bones, but the ones of particular importance are the hip, because a osteoporotic hip is more likely to fracture. Not only is it very painful, but certainly in older people, a fractured hip is associated with an increased risk of death. People get, the treatment is surgical for a hip replacement, usually, or pin and plated, but the pain, the immobility can often, in an elderly, frail person, be associated with a premature death. So it's a very serious and painful condition for the hip. For the spine, which is the other target of concern, is you can get a collapsed spine and the old-fashioned dowager hump, the curved spine that people get. So it's the collapsed vertebra is very painful. The pain often lasts 4 or 6 weeks, and you're left with a legacy that your spine becomes a little bit collapsed. And for your chest, if it happens repeatedly, it obviously compresses the chest and makes breathing a bit difficult. Now, osteoporosis, there are certain well-defined risk factors. Age is one. Parents is another. Genetic factors. So if your parents have got osteoporosis, you're more likely to develop osteoporosis. Sex or gender, I don't know. And again, particularly in Scotland, I've got to be careful which my wording in here. But females are much more prone to osteoporosis, particularly postmenopausal, than males. Some drugs will precipitate osteoporosis, and obviously corticosteroids, prednisolone is the classic example. And liver disease and PBC, again, are well-known risk factors for osteoporosis. What can you do about it? You can firstly choose your parents carefully. Secondly, you can take exercise. Now, what's important with osteoporosis is to have plenty of weight-bearing exercise. So walking, weightlifting, running, all those things are very good in preventing osteoporosis or reducing the risk. Swimming, for example, very good exercise, is not good at preventing osteoporosis because you're not weight-bearing. Avoiding smoking, one of the many side effects of smoking is osteoporosis. So not only do you get the wrinkles, the lung cancer, other cancers, and lung disease, you get osteoporosis. If you need to take steroids for any reason, then you need to take medication to reduce the risk. So I'll come back to medication in a minute. How do you measure or define osteoporosis? Well, in the old days, we just used to use an X-ray of the vertebrae or the hip or other bones, and that was not very satisfactory. It was difficult to quantify it. Nowadays, we tend to use, the first line is diagnosed with what we call the DEXA scan, which is essentially an X-ray, but it enables the radiologists to measure the bone density. And for that, you get 2 scores. Once you get a T-score and a Z-score. One measures your bone density as an absolute measure. The other corrects it for age, because, as I say, as you get older, you're more likely to get osteoporosis. Your bones are thinner. So you may have a reduced bone density, but it is normal for your age. And from that bone density measurements, you can calculate the risk of developing a fracture. And if the risk is very small, then no treatment is required. Obviously, common sense like plenty of exercise and weight-bearing exercise, avoiding risk factors as far as possible. If you have a moderate risk, then usually calcium and vitamin D is what's prescribed. And for most people taking long-term steroids in reasonable doses, again, the recommendation is to give calcium and vitamin D supplements to reduce the impact on the bone loss. I should say that bone loss occurs usually relatively slowly if you're stuck in bed, if you're in bed rest, and equally if you're avoiding gravity, like you see it, for example, in astronauts who are in zero gravity for weeks on end, they will develop osteoporosis as well. So if the bone density is thin and you're at significant risk of fracture, then there are a number of other treatments which include infusion of costonin and other drugs, bisphosphonates. So the treatment, the treatment for osteoporosis is, the first question is, do you need a treatment for osteoporosis? The second question is, what sort of treatment do you need? It's a long-term treatment, and mostly, not always, the treatment will prevent further progression of the bone thinning, and it often doesn't reverse the bone thinning. So again, as with any treatments, you have to weigh up the risks and the benefits.
Mm-hmm.
For osteoporosis, even significant osteoporosis, there are a number of different options. And the advice I would suggest is to go to a bone specialist, an orthopedic surgeon or rheumatologist, and some hospitals like my own have osteoporosis clinics, and discuss with them the various options, the risks and the benefits, and then decide which is right for you. But osteoporosis, if you can prevent the fractures, and you can reduce the risk that if you fall, of breaking a leg, the neck of femur, breaking an arm, breaking an ankle, you're far better off preventing it than treating it. So my advice is, if you do have significant osteoporosis, then treatment is appropriate. If you're concerned about the infusion, again, discuss with your doctors the alternative therapies. You're always at liberty to decline any treatment, but my advice is not. I've seen, and I guess many people have, the consequences of osteoporosis, the fractured neck of femur, and the implications for the many elderly and frail people, the pain, the discomfort, the lack of mobility, and increased risk of death associated with it. So it's worth preventing. And if you're not happy about the treatment offered, look at the other options. Yes, consider, you always, as I say, have the right to decline any treatment, but you must be aware of the consequences, and that may be a fractured femur, fractured other bones, collapsed spine, and so on. So take it seriously. You can prevent it getting worse. Common sense, eating sensibly, physical exercise, don't smoke, not too much alcohol, calcium and vitamin D, yes. But if you need more than that, discuss it with your doctor, discuss the benefits, discuss the potential side effects, and make up your own mind.
Okay, thank you. Moving on to the next question, we've got a patient who was diagnosed with PBC about 20 years ago and well controlled on Urzo. Recent blood tests and a liver fibroscan a year ago showed good results. They also suffer with pseudo gout, having about 6 attacks a year, and for this they're taking Naproxen, 500 milligrams twice daily for about 4 to 5 days maximum. It's the only medication that they've found useful. They've read in a recent edition of the Bare Facts that Naproxen was not good for PBC patients, but there doesn't seem to be a suitable alternative, and they're just a bit concerned that they might be harming themselves if they're taking Naproxen.
This is a challenging topic that we come to time and again, and there's no simple answer. Brufen belongs to a class of drug called the non-steroidal anti-inflammatory drugs, or NSAIDs. Aspirin is one, Brufen, diclofenac are others. Paracetamol is a different class of painkiller. So with NSAIDs, which include Brufen, as ever, you have to balance the benefits and the risks. And there is no doubt that NSAIDs do have side effects. And when you read the patient information leaflet that comes with the medication, you'll see a whole raft of side effects. The ones that are of particular concern in people with PBC are, firstly, they can precipitate more stomach inflammation, ulcers, and other inflammatory conditions, or even bleeding. And secondly, they can affect the kidneys. And if you have kidney impairment, particularly, and liver disease, then non-steroidals can be harmful. So our general advice is be very careful about taking non-steroidals if you have PBC. If you have early PBC, again, the risks of NSAIDs are less than if you have advanced liver disease. But you have to weigh up the benefit, and pseudo gout can be extremely painful, as I'm sure the person knows better than I do. And being in pain doesn't ennoble the soul. It doesn't make you a better person. It just makes you miserable, and you miserable to live with and be around. So you need to treat pain properly. With conditions such as pseudo, and again, the response to pain is very personal. Different people respond differently to different painkillers, and different pains respond differently to different painkillers. And what I often see is that somebody whose pain is well controlled with one pain preparation, over time it seems to become less effective, so you try another one. So you see what suits the person. And remember, you can argue, for example, with jaundice, whether you're jaundiced or not, because you could measure that. Something like pain, only the person who's got the pain knows that they've got it and know how severe it is. So if you say you've got pain, nobody can argue against it. And if it's more than minor, then painkillers are indicated. I think you then have to balance the potential side effects of the tablets against the benefits. And usually if you take short-term non-steroidals and you don't have advanced PBC, they're usually well tolerated. But if there are concerns, if you develop symptoms, you need to let your GP know. You can reduce the consequences of the stomach side effects by taking some medications. The kidney one is harder, and non-steroidals, even in people without PBC, if you take too many, you take them for long enough, you can get kidney damage that is irrevocable.
Mm-hmm.
So, as always, with pain relief, you need to take the minimum effective dose. And yes, there's a risk, but if the pseudo gout is severe, well, yes, you generally do need painkillers. And you can check your GP can check with a blood test if he's concerned about the impact on the kidneys, but take the minimum you need to control the pain for a shorter period of time as you need to, but don't suffer with the pain. Some people find that the topical creams with non-steroidals are helpful. Yes, some of the active ingredient does get absorbed into the bloodstream and so can affect the liver, the stomach, the kidneys, but the amount is far less. So I would, so the general advice is, again, talk to your doctor, discuss your pain relief, think about, usually for things like pseudo gout, topical pain relief, heat, and creams and so on tend to be not that effective, but again, that's individual. And if you need pain relief, you take the minimum amount that controls the pain for a shorter period of time as you need, and have your bloods checked if there are concerns. But don't suffer with the pain. Life's too short for everybody to go around with pain. Take the right painkillers, discuss it with your doctor, check that you're not getting adverse effects, and hopefully that will do the trick.
Yeah, no, that's great. Thank you. Moving on to our next question, we've got a patient who's had near perfect liver test results for the past 12 to 13 years. Last test recorded a significant jump in their readings. We don't have any details of the readings, but it just says a significant jump. And it was 3 days before I was contacted by their doctor, who said to wait a month and then they would revisit them. They've just had COVID and taken antivirals. They did new tests a couple of days ago, and normally the patient would be able to go and see them on their health results online, but the results haven't been posted yet, and she suspects that's because they need to be reviewed by the doctor and that they're still elevated. She's worried that this could be the beginning of the end. Can they stay elevated with no real effects, and could it be that Urso is not working for her anymore? There's a lot in that one.
There's a lot in that. I mean, liver tests are very non-specific, and they can become abnormal for all sorts of reasons. And normal liver tests do not mean that your liver is necessarily normal, and abnormal liver tests do not necessarily mean your liver is damaged. When we take liver tests, people often spend a lot of time looking at particularly lay people, looking at the absolute levels. And say for alkaline phosphatase, then if it's 85 one day and it goes up to 100, some people get very worried. That's not how it works. These tests are not that precise. So if you take blood tests from the same person 4 or 5 times over a day, you'll get some variation. If you get them over a week, again, you'll get some variation. So yes, if they're wildly abnormal, if your alkaline phosphatase, instead of being, say, below 120, is 1,200, then there's something amiss and you need to investigate. But if you get small changes, then your doctors, in my view, did absolutely the right thing, is to repeat them. Sometimes you get aberrant blood tests because during again, the liver test can be affected by how the blood is taken, how it's stored, how it is prepared, how it is analysed. So if you get an unexpected blood result, in general, the first thing to do is to check it. The second point is that liver tests are affected by many different factors. So if you have flu, if you have COVID, if you take certain medicines, your liver tests can become abnormal. If you have another, say, hepatitis, you have some undercooked pork and you get hepatitis E, your liver tests will become abnormal. So there are many reasons why the liver tests become abnormal. And if they are if you're well, you're stable, and the liver tests do flicker, then check it. And then you want to look at the trend. Is the trend going up or down? In which case, there may be something to investigate. And if you're unwell, if you've had COVID, if you've had the COVID vaccine, if you've got a cold, all those things can make your liver tests transiently abnormal. Mm-hmm. Now, getting the results onto the NHS app, again, I think I'm right here, but forgive me if I'm not. One of the strength and one of the weaknesses of the app is that the results may go on before they're reviewed by the doctor. Now, it may be different in different parts of the UK and with different practices. But certainly in my practice, I know that in theory, I can get my results and look at them before the GP does. Mm-hmm. So don't necessarily read anything good or bad into the fact you haven't been contacted. GPs around the UK are under enormous pressure at the moment. They have been for years, and it's increasing. Urgent things get dealt with more promptly than minor things. I wouldn't read too much into the fact that you haven't been rung or they're not available to you. Obviously, if you don't hear in 3 or 4 days, it won't do any harm to email the surgery, leave a message and say what's happening, but don't assume the worst. Of course, it's natural human reaction to think things are going wrong. Mm-hmm. But again, it depends how the liver tests are going. But if you feel well, my guess is it's likely that it's an intercurrent infection and they will settle down again. Of course, that you need to be sure that happens. You need to check that they are settling down. And if they're not settling down, you need to find out why. Yes, it could be the PBC getting worse, but my guess is if you're well, if it's early disease and so on, that wouldn't be top of my list. I'd look for other factors, mm-hmm. and particularly if it's related to an illness, I'd be less anxious. But obviously, you need to find out what's going on. Don't let it drop. If you don't hear from your GP within the week, then I would certainly ring the surgery and check. But you want to look by and large at trends and not spend too much effort in looking at small fluctuations. If you take normal healthy people, you get fluctuations. And as I say, if you have an illness, again, abnormalities in liver tests are not uncommon. But don't ignore it, and equally don't read too much into the fact you haven't been rung. Mild changes in liver tests are rarely urgent. It's and if you're well, but don't ignore it. If you're ill, ring your GP. If you don't get the results in a few days, again, ring the surgery and say what's happening. but don't assume the worst. But equally, don't ignore it. Take it seriously. See how it goes.
Yeah, just picking back up on the last part of that question, James, it mentioned about, could it be that RSO is not working for me anymore? From reading the question, it looks like for about 12 to 13 years being on RSO and being fairly stable, and I know that's something that's been asked before. If someone has been quite stable on RSO for that length of time, is it, in terms of someone responding to RSO, is that likely to remain the case?
Usually people do remain URSO responsive, but not, as you imply, always. The first thing to do is to check, is the dose still the right one? Have you had a different preparation of URSO with perhaps a different, so instead of getting a 250 milligram tablet, you're getting a 150 milligram tablet. So check you're on the right dose for your weight. And then if your liver tests are starting to go off and it is attributed by your doctor to the PBC, then you would normally discuss second line therapies and obviously fibrates, OCA and so on. But people don't always remain URSO responders. It's unusual, but it occurs. And you just want to be sure that it is the PBC and not other factors, and then think about alternate treatments. But it's, again, these things to be taken seriously. And uncertainty is always unsettling. People can put up with bad news much more readily than they can put up with no news.
Yeah,
so don't read too much into it. I would say, I think when people say try not to worry or try not to think about it, I often think those are really stupid comments, because you can't, I at least can't stop worrying about things if I am going to worry about them. But do take it seriously, but don't read things into it too far. This theory about, is it cock up or conspiracy? In my experience, it's nearly always cock up.
Good to know. Good to know. Right, so moving on to our next question. The patient has heard from another question and answer session that it's common for cholesterol to be raised. Is it advisable to take statins even if there is no other reason to take one, i.e. high blood pressure, etc.? So I think that's asking about taking statins routinely because you have PBC, if it's common for cholesterol to be raised.
Yeah. Moving for people without PBC, the evidence that statins are beneficial, and this is somewhat outside my area, so there is increasing evidence that statins are beneficial even in people with normal blood cholesterol. And they do seem to reduce the risk of stroke and heart attack, amongst other things, maybe of diabetes, maybe of Alzheimer's. Statins are now fairly cheap, but they do have side effects. And the side effects can be quite significant. So as you get older, the benefits of statins become greater. And NICE in England and Wales has recently changed its guidance, and more people are being advised to take statins. Yes, there's a risk with it, but the trials are very, very clear that in appropriate patients, the risks of statins are far outweighed by the benefits. Now, going back to PBC, the first point to make is that the studies that have been done have shown that the risks of heart disease in PBC people is no greater or less than in similar matched controls. But The cholesterol in people with PBC is usually elevated, is increased.
Okay.
Now, they're good, it's a bit superficial, but this is how I think of it, so I'll pass it on for what it's worth. There's good cholesterol and bad cholesterol. And looking at total cholesterol gives you only a very skewed part of the picture. You look at the different components of the lipids and the different ratios, and that will help the experts decide what your risk of getting heart attack or stroke is, and therefore whether the risks of statins are worth taking, in their opinion. Now, in people with PBC, the total cholesterol is usually increased, and it's increased by a form of cholesterol called lipoprotein X, which is not a bad cholesterol. So your total cholesterol will be increased, but it doesn't necessarily carry the same connotations as somebody with a normal cholesterol without PBC. So my advice is to talk to your doctor, to get advice, if necessary, from a lipidologist. I wouldn't put too much weight on the cholesterol level itself. I would look at issues like the age, gender, family history, other risk factors, diabetes, smoking, and so on, and then discuss the risks and the benefits of statins. But as experience has grown with statins, particularly drugs like atorvastatin, simvastatin, yes, they have side effects, some of which can be severe, can be serious, but the benefits usually outweigh the risks. So again, like with the non-steroidals, you've got the benefits, you've got the risks, and it's up to the individual to take a decision whether they take, if the advice is to take statins, then it's your right to decide whether to take that advice. But obviously, either way, it's your decision and you carry the consequences. But the way things are going in general is to have a lower threshold for statins, because they do seem, for most people, to be well tolerated and effective. The trouble is that if you take a statin and you don't have a heart attack or stroke, you'll never know, was that because you took the statin, or would it not have happened anyway, because you got run over or something. So you never know in these situations whether the statin works. But if the risk factors are there because of age, whatever, then personally, I would have a low threshold for trying statins. If you get side effects, well, then obviously it's a different scenario. So it depends how high the cholesterol is. It depends on the other risk factors. It depends on the other blood tests, the other types of cholesterol. and then talk to your GP and get advice about the risks, the benefits, and take it from there.
Okay. Moving on to our next question, we've got a patient who has had a gastric sleeve before diagnosis of PBC and is considering a gastric bypass as their weight is climbing again and has sleep apnea and high blood pressure and is on statins for cholesterol and an underactive thyroid. Is there any reports as to how this procedure might affect PBC sufferers, and any advice that you could give would be gratefully received?
Yeah, sleeve gastrectomies and other forms of what we call bariatric surgery do have a place in treating significant obesity. And being overweight is a very complex situation. And treatments are difficult And without going into the complexity of eating disorders, there is no doubt that being significantly overweight has not only a psychological consequence, but also a physical consequence. And various surgical approaches to prevent or reduce the risk of a high BMI are well developed. Now, there is good evidence that bariatric surgery, as you call it, that's any form of surgery to help people lose weight, does greatly improve the outcome, not only in terms of heart attack or strokes, but mobility and psychological well-being. The concern, and quite a lot of people with liver disease do have cirrhosis as a consequence of being overweight, of being with a high BMI. And in those patients, bariatric surgery in selected patients is effective. They're usually the ones with non-alcoholic fatty liver disease. The issues with surgery in PBC, particularly around the stomach, is if you have portal hypertension, if you have significant scarring within the liver, significant fibrosis, whether it's on the FibroScan or on the ELF test or what have you, then you get portal hypertension, you get bigger varices around the esophagus, the gullet, and the stomach. And that makes surgery much more difficult because you have these big vessels with thin walls and they can bleed if you're not careful. Also, of course, people with advanced liver disease from any cause are more susceptible to infection, bleeding control, and so on. So technically the operation is difficult. There are risks, but equally the benefits are great. So in PBC, so I think the first thing is bariatric surgery indicated and appropriate in people without PBC in that situation? And that again very much depends on the individual state of the patient. Other treatments have been tried, and so on. If you throw in the PBC, then again, if it's early PBC, the additional risks will be small. If it's advanced liver disease, again, PBC or anything else, the risk will be greater. But as always, you have to balance the risks and the benefits. Yes, if you've got PBC, the risks will be greater than if you didn't have it. If you have early PBC, the risks will be less, additional risk will be less than if you have advanced liver disease. So, as always, you think of the options, the risks, the benefits of surgery, the risks and benefits of other treatments if they haven't been tried, and the risks and benefits of no treatment. And then you make a decision. So there's no right answer. Yes, PBC may increase the risks of the operation. I don't think it'll have anything to do with the effectiveness of the surgery. But again, talk it over with your surgeon. They will, I imagine, talk to the hepatologists and so work out your individual risks and make a decision either way. So if it's indicated, take it seriously and go for it, or consider it carefully. Discuss with the hepatologist and the surgeon the risks, because the increased risks and also the benefits, and then make a decision. Usually, I think, with most operations, people know in advance what they're going to decide, and knowing the risks and so on doesn't greatly alter them. but the law is very clear. You have to be told the risks so you can make an informed decision and with your doctors decide what is the best way forward for you at this time. But bariatric surgery does improve the quality and increase the length of life. Yes, PBC may increase the risks, but again, not to a huge extent, and you've got to balance those risks against the benefits.
Mm-hmm.
So talk to your as always, talk to your doctors and look at the risks, look at the benefits, and then make your decision. But I think for most of my experience, when people are talking about bariatric surgery, they know what they want. As long as you go in with your eyes open, as it were, not literally when you have the surgery, close them then, and also make sure your family understand the risks,
Mm-hmm.
but also understand the benefit. It's not their decision, it's yours. And get yourself in as good a position as you can for it. So, you know, if you are smoking, stop, and get your exercise as good as your condition will allow. But these are difficult scenarios. They're not only physical, but psychological, and for many people, emotional. And it's important it's taken seriously. But if it's indicated and the liver disease is not very advanced, I suspect I know where you're going to go with that.
That's
but it's
great.
your decision with the doctor's advice.
That's great. Thank you, James. Just moving on now to the last question that we've been sent in for today. Is there a link between PBC, vitamin B12 deficiency, and pernicious anemia, if I'm saying that correctly?
Yep. Pernicious anemia is a form of anemia. Anemia just means a low level of hemoglobin. And there are many causes of that. The most common cause, probably in the UK, is iron deficiency. People aren't having enough iron in their diet. In America, it's probably bullet wounds, but that's another issue. There are three elements that are primarily important with anemia. One is iron deficiency, and the second is folate deficiency from not eating enough green leaf vegetables. Folate is a vitamin. It's called folate because it comes from leaves, and the Latin for leaf is folia. And then there's vitamin B12. Now, vitamin B12 is absorbed from the diet, and to absorb it, you need a chemical called intrinsic factor. This intrinsic factor is secreted by the stomach, and it combines with B12, vitamin B12 in the diet, and only if you have intrinsic factor binding to the B12 do you absorb it. So if, for example, you have, as in the old days, or the last, a lot of your stomach removed, particularly the part of the stomach that produces the intrinsic factor, then you will get pernicious and B12 deficiency. Pernicious anemia, is usually a consequence of an immune attack on the intrinsic factor, so that you don't produce intrinsic factor, and then you don't absorb the B12. The treatment of B12 deficiency, if the dietary intake is good enough, then the treatment is injections of B12, and they are usually done every 3 months or so. Sometimes they're done monthly, that's often not necessary. And the consequences of B12 deficiency are not only anemia, but there can be neurological damage as well, so it's serious. So pernicious anemia or B12 deficiency can be associated with PBC because it's pernicious anemia where you get the antibodies to the intrinsic factor. It's an autoimmune disease. And as I hope many people who are still awake and listening will know, that PBC is associated with other autoimmune diseases, including pernicious anemia. There are other factors why people may be B12 deficient, which are not related to pernicious anemia. But the short answer, and I know I'm not giving short answers today, which apologies, long-winded is very much the nature. I'm apologies for that. Is that yes, people with B12 are more, or with PBC are more likely to have pernicious anemia than the general population. Your doctors, so with pernicious anemia, you get a low hemoglobin and the red cells are bigger than normal, not smaller. With iron deficiency, the red cells tend to be small, what we call microcytic, which is just pompous for small, whereas in B12 and folate deficiency, they're bigger and what we call macrocytic anemia. Liver disease itself can give you a macrocytosis as well. So you make the diagnosis of pernicious anemia usually by showing a low B12 in the blood, and that just shows you have low B12 levels. It doesn't show you have pernicious anemia as the cause. In the old days, you used to do something called the Schilling test. Now you probably just look for antibodies to the intrinsic factor. And for most people, I think it's enough to make the diagnosis. And the treatment then is lifelong B12 injections every 3 months or so. As I say, if you have bowel disease like celiac or whatever, there may be other causes for B12 deficiency. So yes, it's associated with it. The treatment is B12 replacement, and because and it's usually caused by non-absorption, it has to be given by injection, and most people will give it every 3 months or so. But again, your doctors may give a different regimen for you.
Mm-hmm. I appreciate we're getting to the end of time just now, but I've got a couple of questions on Facebook that I'm going to ask, if that's okay with you, James.
Of course, yeah. Is
that okay? We've got a patient who has had PBC for 22 years. Blood tests have showed that they are stage 3 CKD, and they're really worried because their sister, who also had PBC, had a transplant and ended up dying with kidney cancer, and she's really worried about this. They live in Spain, and their consultant is not very interested in discussing the PBC itself. Is there any advice that we can give for
her? I think to discuss the PBC itself, she's obviously doing the right thing and getting in touch with the foundation. I think in general, if you don't have confidence in your doctors, then you need to change to a doctor where you can feel that you can talk. As far as the CKD is concerned, and again, this is way outside my knowledge, but I don't think CKD and renal cancer are necessarily related. CKD, there are many causes, and again, if there's significant renal impairment, it's a good idea to see a renal specialist. There's usually not a lot that you can do to prevent renal impairment progressing. There are treatments. You can also avoid factors which may precipitate CKD, like treating blood pressure properly and actively. But I think if there's significant renal impairment, to see a renal specialist is wise, even if they say we needn't do anything about it. But it does need to be taken seriously, and the person needs the advice that they can get. For the PBC, as I say, talk to the foundation. If you're unhappy with your doctors, firstly, let them know you're unhappy, because no doctor or nurse or anyone else wants to go into work doing a bad job. so let them know what, and also, if you're not happy, tell them what you do want, because it's speaking as a medic. If people, I don't like it when people are not happy with the treatment I give or the care I give, but I'd like them to let me know, and let me know what they want, so that we can do our best to provide it. But if you're getting nowhere, then talk to your GP about getting referred elsewhere. Again, with the chronic kidney disease, I do think that in general needs specialist opinions. Your GP may be expert in that. If not, you can discuss about a kidney referral, just so you can understand from a specialist what's involved. And and particularly if there's a family history of kidney cancer, then in kidney disease, then of course you're anxious, and you'd want to be reassured as far as is possible, and given the information you need, if that is surveillance appropriate, is screening appropriate. That's advice which, again, I'm not in a position to give, but talk to your GP, think about a renal opinion if they think it's appropriate. But to get the answers you want, and before you go in, as always, try and think of the questions that you want answered, write them down, and take somebody with you to help you remember.
Yeah. And also, if the patient wants to chat that through with us first, then please give us, we call it the foundational helpline number, and we can chat you through how to prepare for your appointment and the things that you might want to ask for that. So we're absolutely here to do that as well.
I mean, accurate information doesn't make things better, but they make them easier to cope with. Then you know what you're dealing with. And I remember, sorry, I'm rabbiting on, I know we're past time now, but when I was starting off as a houseman, there was a lady we were investigating for gastric cancer. And we were fairly sure she had stomach cancer. She thought she had it. And when we finally proved it, and I told her, her reaction was one of relief, because now I can stop worrying and I can start planning. And she had surgery and did well. And that had a profound effect on me. It's the unknown that's the mental killer.
It absolutely is. And I think the more the patient knows, the more the patient can feel in control as well, and understand the treatment plan and what's coming. So yeah, I absolutely believe in that as well. That's great, guys. There is a couple of questions on Facebook that we still have. I'll make sure they're added into our list for next week as well. But thanks so much for joining us today and giving us your time to go through the questions. That's really much appreciated.
And enjoy the good weather.
I know, yeah. Get off and enjoy
it won't last like everything else that's good in life.
Yeah, because we don't. Another thing is we don't know how long it'll be here either, do we? So that's one thing. So thanks very much for your time today, and thanks to everyone who joined us online as well and for submitting your questions. We really appreciate it. Okay.
Okay. Cheers then.
Thank you. Take care. Bye.